Our next speaker, Dr. Rachel Rubin, is a urologist with a specialty in sexual medicine. She is an expert on both male and female sexuality. She's smart, she's funny, she delivers things straight up. Oh, that's a bad choice of words, but her title is Sex Ed for Grownups, and I think you'll see why. Dr. Rubin.
Thank you so much for having me. I'm so thrilled to be here today. I'm Dr. Rachel Rubin. I'm a urologist with fellowship training in sexual medicine. Very few people in the country are fellowship trained in sexual medicine, and even fewer are fellowship trained in both male and female sexual problems. In fact, there's only one fellowship in the country that even acknowledges female sexual health, which is pretty wild if you think about it. I'm so honored to be here. Please feel free to reach out on Instagram or Twitter. We spend a lot of time teaching about sexual medicine and sexual health. Come visit us in Washington, D.C., where Dr. Jim Simon and I are lucky enough to practice together. He is the menopause whisperer, hormone specialist, reproductive endocrinologist, and I am the yin to his yang. I am the urologist and sexual medicine specialist. I've coined myself as DC's premier clitorologist, which hopefully we'll talk more about. Today, I want you to never forget the consequences of sexual medicine. You got to be careful out there because babies can happen. And so we talk about safe sex, but really pandemic has taught me, these are my small humans, and my goodness, things have been challenging this year during a pandemic with small humans. I want to talk to you today about sexual medicine, about what it means, what it is. It's not something we regularly talk about. I always start with jokes. If you can't start with jokes, what's the point of living? I see men and women in my practice. I see all genders in my practice. And really, we have this underlying idea that our male patients are so simple. They're just an on-off switch, but women are so complicated. Oh my gosh, they have all these buttons and bells and whistles, and it is not true. Gosh, my male patients are just as complicated. They've got emotions and feelings and behavioral health issues and all sorts of things to figure out. And my female patients are not as complicated as we give them credit for. So really, what is sexual medicine? What is this? Who's responsible? What kind of doctor do you go see? And really, who should be taking care of your sexual health issues? It is a very wonderful field. Why I love it so much is because I work with doctors like Dr. Simon, who you'll hear today, and Dr. Cheryl Kingsburg, who you'll hear today, who you have a gynecologist, a mental health professional, myself, who's a urologist. It is, nobody owns this field. It's so multidisciplinary. And it really, the key is to see someone who cares about this. See a menopause specialist. See someone who actually takes your sexual health and your quality of life seriously, because quality of life, why are we curing cancer? Why do we keep you around for a long time? It's to have a quality of life, and that can look however you want it to look. So often, a sexual medicine specialist will get other people involved. We work with pelvic floor physical therapists who work on the musculoskeletal issues of the pelvis. We work with primary care and gynecology and urology. We work with sex educators and sex therapists who definitely can help a lot with each person's issue. I don't know about you, but this is how I learned sex ed. I still remember the middle school gym teacher who taught me sex ed. I remember very little about what I was taught, but this is this universal idea of how are we learning about sex education. It starts and stops in middle school, and we really don't get much after that. There is no curriculum, there's no adult sex education, and that's a problem. So whether I'm talking to a patient who is 16 or 98, they've had about the same sex education, which is pretty upsetting. Not only that, but we're dealing with a lot of snake oil on the market. We've got people who are telling you you need to put jade eggs in your vagina, or you need to go to some strange oils that you dab on your face, which is going to cure all of your ailments. And it's just, I'm here to say we have to fight this. We have to stick to evidence. We have to really focus on the medicine and the biology and really what is true and what is not true. I tell you, for my female patients, we have a long way to go. This is, I'm a urologist, I see men, and it's a lot easier to delve into male sexual medicine. There's a lot more available on the internet. There are a lot more medications available, and it's often easier for people to talk about. This is an advertisement on the right in the New York City subway system for an erectile dysfunction organization, which has advertisements everywhere. And yet on the left, it was a female vibrator company that tried to advertise a small vibrator, a very tame ad, and it was not approved by the New York City subway system. So we have a real disconnect between what we allow for male sexual health and what we allow for female sexual health. We have a huge gap in this country, not just a pay gap. We have what's called an orgasm gap in this country. So we know women are paid 80 cents on the dollar. Well, it turns out women have much fewer orgasms during sex than their male counterparts if they're in a heterosexual encounter. So straight men orgasm about 95% of the time during a sexual encounter, whereas straight women are way at the bottom. It's about 65% of the time. We must do better for female equality and getting women to realize that their pleasure is important, that their orgasm is important, and most of the time, about 82% of the time, it doesn't happen from penetration. So that means when orgasm happens, it's outside of penetration, and that should be called sex. That should be a part of the sexual experience. Why don't women orgasm as much as their male counterparts? Well, probably because it takes them a little bit longer. A man will orgasm, you could take a stopwatch, we have those studies, a man will orgasm in about 5.5 minutes on average from entering a vagina to when he has an orgasm. Women, often 82% don't orgasm from penetration, and with partnered activity, women can take up to 15, 20 minutes in order for them to have their proper arousal and orgasm experience. What's interesting is data when women are alone, it's much faster. It's about that 5.5 minute time period, just like their male counterpart. So we have to understand the biology. And when you know what is quote unquote normal, then you realize, I can only have an orgasm outside of penetration. Okay, you're normal. How can we make sex more fun, more interesting, and more enjoyable? Sex education in this country is abysmal. We already talked about it. These are where the hash marks are states where sex ed must be medically accurate, let alone have sex ed at all. So we're far away from really encompassing a comprehensive sex education where we can teach young people about healthy relationships and consent and safety and body image and mental health and all the really important things that go into understanding sexuality. And as I said, I don't care if you're 74 or 17, you need this education. There is not an age where quality of life and sexual health is not important to people. We know from data that people don't think their doctors care about their sexual problem. When asked, 87% of people said, when I brought it up, I got no follow-up from my doctor. 85% said the doctor didn't give me a diagnosis. 76 said, well, the doctor didn't even examine me. And 52% think their doctor doesn't want to hear about their sexual problems. And I'm here to say that's probably true for most doctors. You have to seek out medical providers who care about this, who are passionate about this, and who want to hear about your quality of life and try to figure out how to make it better. Women and men are not always the same. There are a lot of similarities, but we have a lot of arguments about, well, what is normal desire? Does a woman have spontaneous desire? They just think about sex every 3 minutes, or do they have what's called responsive desire? Partner initiates, I think I could get interested in this, I like it, and then more desire comes from there. It turns out women can have both. Some people have more responsive desire, some people have more innate desire. Sometimes Wednesday I had responsive desire, but Thursday I had innate desire. That makes you normal, but are you distressed by your level of desire drop? Are you distressed by the fact that it hurts to have penetration? These are things, if you are bothered by your sexual health, then it is a medical problem and there are professionals who can help you. This is such a wonderful field that is so what we call biopsychosocial. I have to understand what's going on with your biology, with your hormones, with your bones, with your muscles, with your nerves. I have to understand the mental health aspects. What is your relationship like? What is your cultural upbringing like? It is such a rich and wonderful field. And gosh, I love going to work every day because I get to know so many intimate details about my patients and really help them through ways that we can enhance their quality of life. Biology is everything. When you understand how your body works, then you can control how you fix it or change it or alter it, or at least understand maybe why it's not working as well as you want it to. I'm going to start with a case. I think it's really interesting to see a patient who I've worked with and how dealing in this biopsychosocial approach can really be helpful. This is a 57-year-old female patient of mine who came to me with symptoms of low libido, painful sex, hot flashes, night sweats, and urinary frequency, urgency, and recurrent urinary tract infections. She's been married for more than 20 years. Her husband is at home with the kids. She has a demanding and exhausting job. Her children have had medical issues. Her relationship took a third priority. They went to marriage counseling, found out her husband had been depressed and isolated. He's doing therapy himself. But something changed with menopause. She said she feels like things have really changed, like someone turned off all her nerve endings. She would like to feel more of an interest in sex. I'd like to feel my body can respond in a positive way. Her urinary tract infections, they had tried all these supplements, and she had tried a vaginal cream, but she didn't know why she was using it. She felt like it didn't help, and she just didn't refill it. Orgasm. She can have an orgasm from external stimulation. Remember, that makes her normal. She says it's harder to have than it was before, which is so annoying. She even has distressing leakage of urine when she has an orgasm, which happened in menopause. She didn't used to have that. And she feels like her libido is so low. It's been low for a long time. She really can't arouse. She can't lubricate. She can't engorge. It hurts, right? Sex hurts with penetration, has a lot of pain at the opening of her vulva. Her period stopped around 50, so about 7 years ago, and she's got hot flashes. They wake her up at 4 a.m., night sweats, brain zaps, brain fog. Her sleep has been terrible. Past medical history, she's otherwise healthy. No real surgeries, no allergic to sulfa drugs, no medications. She's got a high-powered, I'm in DC, all my patients have the most incredible, high-powered, incredible jobs. She and her husband have been together for 20 years. They've got kids with some medical issues, hobbies, she's working on it. Gosh, I've been taking care of everyone else. I've been working my butt off for so long. I don't even know what I like anymore, which is something she really wants to change. She's a non-smoker. She has not so much alcohol. So, oh my God, have you ever had a doctor ask you these questions? Have you ever taken the time to talk about these things with your doctor? I don't know about you, but in the 10-minute doctor visit, there is no space for that. There is no place for me to just talk about myself or talk about my quality of life or my relationship. It doesn't work. And so seeking doctors who care about these issues is really important. I have all of these, ask all of these questions to all of my patients, and I take time to really listen to the answers and work with them on ways we can really improve their situation. So menopause, the period stop, hooray, no more bleeding, but the pain starts. And that's what we have to really talk about today, is trying to understand the role that hormones play in the body and in sexual health. So hormones, you're going to hear a lot about hormones, hopefully, during this conference, and I'm just a small part of it. But hormones are just a bunch of carbons, hydrogens, and oxygens. It starts with cholesterol, and that cholesterol can turn into progesterone, testosterone, estrogen, even cortisol or aldosterone, which is important for blood pressure management. In and of themselves, hormones are not scary, but the media has really turned them into being these very scary things that we must be fearful of and never use. What are we treating when we treat women in menopause? Gosh, in my opinion, menopause has the worst PR campaign in the history of the world. Why? Because we think menopause is just hot flashes and night sweats. And once those are gone, or if I didn't have those, then I got through menopause easy. And I'll see patients all the time where they may not have hot flashes or night sweats, but they have urinary tract infections, pain with sex, low libido, and osteoporosis, and they think they have no menopause symptoms. symptoms, whereas those are all menopause symptoms. Menopause is just when your body is free of any hormones, of the sex hormones, estrogen and testosterone and progesterone, and how the body responds to that is menopause. Listen, we weren't supposed to be alive past 50, but here we are living until 100 and spending half of our lives in this menopausal state. So if you want to have a sharp brain with healthy bones, a healthy sex life, and no urinary tract infections, it's important to give your body back what it no longer has. And so when we treat menopause, we're treating headaches and hair changes and skin and risk of cardiovascular disease and backaches and urinary frequency and urgency and bones and vaginal dryness. We're treating all of those things when we treat a woman in menopause. It is not even just hot flashes and night sweats. When we talk about vasomotor symptoms, which is doctor speak for menopause, doesn't feel so good. Your sleep changes, you get mood swings, brain fog, right? I get this all the time. Geez, what is this called again? It's on the tip of my tongue. Oh, it's a pen. Oh my gosh, I couldn't remember. We see a lot of anxiety and fatigue, disruption in family relationships, social isolation. I see a lot of this during pandemic, but these are all things that really aggressively come up during this perimenopause, menopause transition, and they can sometimes last. We know hormone therapy works to help all of these symptoms. It works a lot better than vitamins and exercise and meditation. All of those things can help and are good, but they are not going to replace your body's own ability to produce these hormones. Genitourinary syndrome of menopause. Everyone at your computer, say with me, GSM. Say GSM, genitourinary syndrome of menopause. GSM is the most common thing we see every day, and yet no one's on treatment. Less than 6% of women in menopause are on treatment for their GSM. GSM is what happens to the genitals when they don't have hormones. Without estrogen and androgens like testosterone, the vagina becomes dry, a decreased lubrication, pain with sex, bleeding after sex, decrease in arousal, orgasm, desire, itching, burning. But it's not just about sex. Women have pain with urination, urinary frequency, and urgency. And what happens? The vagina loses the strength. It loses the wrinkles inside of it. It becomes flat. It becomes pale. It becomes fragile. The urethra protrudes on the floor. It really protrudes out. You lose, this is the craziest thing, your labia minora, those inner wings, resorb and go away. They disappear. Okay, if a penis shrank at age 52, we would have vaccines for prevention. Am I right? So labia go away. They completely disappear. Why? Because the lack of hormones keeping the tissue strong and healthy. As estrogen drops, pain with sex goes up. It's not magic. It just makes sense if you understand the biology. And so if I could buy a billboard, I tell you, and I don't want to shock anyone here, I'm going to show you a picture of a vulva. Okay, so if you want to shield your eyes. But if I could buy a billboard, this is what would go on my billboard. Why? Because I don't care what language you speak. I don't care your education background. I don't care if you know anything at all, but you can look at these two pictures, the one on the left and the one on the right, and say, which one do you want? The vulva on the left is pink, it's wrinkly, it's stretchy. The urethra, the tube you pee through, is hidden. It lubricates. It doesn't hurt with wiping. There's no constipation. There's no pain with sex. The one on the right is menopause. This is what happens in menopause. You lose the labia. It is red, raw, irritated. It is pale. The urethra is almost on the floor. I tell you, cranberry pills aren't going to fix that. I treat a lot of erectile dysfunction. If we give men erections, where would it go on the vulva on the right, should he want to use it somewhere? So we have to understand what happens to the tissue. This is what happens to the tissue when there is no hormones replenishing it. Okay, you can open your eyes now if you've closed your eyes. This is a pelvic floor and a vulva. Hopefully you're not too grossed out by that. And again, why are we so grossed out by these things? We don't get grossed out looking at our arms and our legs, but genitals give us so much shame. Not a woman comes into my office who doesn't go, ugh, I wish, my men don't do that. They pull their pants down. They don't get grossed out by, an exam of their genitals, but women have this genital shame that we really have to move past. So how does having tissue that is red, raw, and irritated affect the rest of your pelvis? Well, your pelvis is just muscle, and all of this muscle does not like to be in pain. And so these muscles can tighten. They can tighten so much that sitting hurts, that wiping hurts, that penetration is impossible. And the hormones, you need hormones for muscle health, right? You see those bodybuilders at the gym, who are on high doses of testosterone. You need hormones in your body to keep muscles healthy. And so you can see urinary symptoms, frequency, urgency, leakage. Constipation is a big one that we see, and many of it can all come down to the lack of hormones in the body. GSM, the genitourinary syndrome symptoms that you have during menopause are easily treated. They can be treated actually very locally. So maybe your doctor said you can't have hormones for your whole body, or maybe you have someone with breast cancer who is in so much pain and can't have hormones for their whole body. These are treatments that you can do just locally, just to fix the local vaginal symptoms. There are creams, there are inserts, there are rings, there is even a pill that you could use. And it's really important that you and your doctors talk about using one of these products to help with some of these GSM symptoms. Education is essential here. If you don't know why you're using it or how to use it, it will not work and you will not get the appropriate treatment. Maybe you have a patch and gosh, well, I have estrogen for my whole body, but I have frequency and urgency and recurrent urinary tract infections. Maybe you need something locally too. Maybe the patch isn't getting enough down below. Treating GSM does not work if it's too expensive for you to pick up at the pharmacy. It doesn't work if it's too gooey that you don't like it and that it stays on your nightstand. If it sits in the bathroom drawer unopened, I promise you it will not work. If you don't get it refilled, yeah, it'll work when you use it, but when you don't get it refilled, it will stop working. It is not like a yeast infection where you take a medication once and boom, you're better. This is lifelong therapy that you have to do to maintain vaginal health and integrity so you can fight urinary tract infections, so you can fix the frequency and the urgency and help with some of those symptoms. It also doesn't work if you read the box and read all the warning labels and say, oh my God, this medication is going to kill me. What is Dr. Rubin even thinking? And that's where we get into policy and politics and your FDA and all of this craziness, which hopefully more people will talk about today. But when you look at just this local treatment, a local vaginal cream or tablet does not increase your blood levels. It won't help you with hot flashes. It won't fix your bones. But even just that local therapy, on the box, it says it's going to give you strokes, heart attacks, blood clots, cancer of every kind, and you have to use progesterone with it. None of that is true. None of it. Actually, they sent a letter to the 22-page letter to the FDA and said, this is not true. Why do we have this box on these local vaginal hormone therapy products? And the FDA took 2 years to respond, and they wrote, yeah, you're right. We know there's no evidence for it, but we're going to keep the box on there anyway because we're the FDA. I'm sure it's a little more nuanced than that, but this is the struggle that we deal with. Women are not picketing in the streets for their vaginal hormone therapy. It's also incredibly expensive for many women to get, and it's a huge problem for lower income or people without insurance. And so we really have to work on the advocacy side of things to change things. But we know with very long-term data, 18 years, that the risk of cardiovascular disease, cancer are not elevated in women using vaginal estrogen products, vaginal hormone therapy. So local therapy for GSM does not show you an increased risk of anything dangerous. And so that's my issue with it, is women can be so afraid to use these products, whereas there's not a lick of evidence that shows that they cause harm. Sexual dysfunction in menopause is so common. Early in menopause, we know, 42% of women have sexual dysfunction, and late in menopause, 8 years later, like my patient who we were just talking about, 88% have sexual problems. Now, we know that if you use systemic hormones, meaning a patch, or a ring or something that fixes your systemic level, so fixes with your hot flashes and your night sweats, not just a local therapy for GSM, we know that it improves sexual problems. This study came out not too long ago that said actually the pills, the hormone therapy by pill isn't as good as helping with sexual function as a patch or a ring, and that's probably because the way the pill goes through the liver. So for me as a sexual medicine doctor, I tend to prescribe transdermal products, the patches, the gels, the rings, as opposed to oral hormone therapy. Not that that is not safe, but that I think about the sexual problems that they are creating. So estrogen, when you're treating someone for their whole body with estrogen, you can do rings, creams, gels, sprays. There are multiple ways to do it. If you have a uterus and you want hormones for your whole body, you need progesterone to protect your uterus. Progesterone, it's like a lawnmower. It keeps the grass cut. Estrogen grows things. It makes your bones healthy, your skin healthy. It grows also the lining of your uterus. So to prevent uterine cancer, you use progesterone. It was actually that big study that scared everybody and said, oh my gosh, hormones cause cancer. 18 years later, the study shows that women who were only on estrogen, so those who did not have a uterus, who took systemic estrogen, had a decreased risk of getting breast cancer and a decreased risk of dying from breast cancer. And women who had a uterus, who were taking both estrogen and they took a synthetic form of progestin, they had a slight increase of getting breast cancer, but no increased risk of dying from breast cancer. This is the study that scared everyone and said, oh my gosh, I can't use hormones. We don't even use those type of hormones anymore. These were synthetic pills that people took that were not FDA natural forms of estrogen and progesterone. So this data is based on old medications that we don't use very much anymore. And if you take more natural forms of hormones and you look at studies and you use estrogen and a natural form of progesterone, there is no increased risk of breast cancer. It's really important that you understand hormones are not hormones are not hormones. A local hormone for your vagina is different than a hormone for your whole body. A synthetic pill is different than a natural FDA-approved product that goes on your skin. And so you have to understand the biology. When you understand the biology, you can fight the snake oil or the misinformation or the fake news. And so educating yourselves is the most important thing that you can do. What about testosterone? Okay, well, testosterone, only men have testosterone, right? It's not true. As a female, patients actually have more testosterone during your reproductive years than you even have estrogen, but we never talk about testosterone in women. I treat men for low testosterone. I also treat women for low testosterone, but I do it at about 1/10 of the level as I do my male patients. So men need about 10 times more than their female counterparts. Testosterone, we know, is important for desire. It helps with arousal. We know if you give a transgender male, so a female who wants to transition into being a male, you give high doses of testosterone, the clitoris grows. It can grow so big they can sometimes penetrate with it. It is hormone sensitive tissue. So we know testosterone can play a role in sexual health. So in my patients who have these menopausal symptoms, I will often treat them with some estrogen for their body, some progesterone to protect their uterus, and some testosterone to help with their libido, as well as a local therapy to help with the GSM symptoms. So what happened with this patient? Back to the case. She came to me with pain with sex. I could have just given her a local product to help with her painful sex, but I didn't. I really talked to her. I talked to her about her hot flashes, her night sweats, her brain fog, her poor sleep. So we put her on an estrogen for her whole body, got rid of the hot flashes, got rid of the night sweats, a progesterone to protect her uterus, which is a nightly pill that makes her sleepy, so it helps with her sleep. We put her on a local therapy in her vagina to make sure the pain with sex went away. And we started a little testosterone to help with her libido. Once we did one thing at a time, we checked levels, we checked lab values, we checked in with each other. In about 6 months, when we got everything right, she came back to see me and she said, Dr. Rubin, I came to see you for pain with sex. Yeah, it doesn't hurt anymore. But I didn't think that I would like it again. I didn't think I would want it again. I didn't ask you for that. And it was just the most powerful moment, because it was really, she had done therapy. She continues to be in therapy. They're working on communication. But it was a lack of having any hormones in her body to give her that thought, the feelings, the fantasies, the quicker orgasm. Her body had changed because of not having hormones in it. And so by thinking about her in a biopsychosocial approach, by thinking about understanding her relationship, understanding communication, her cultural background, her biology, then we were able to make changes in her regimen to really help her live her best quality of life while she continues in menopause. Menopause doesn't end. It keeps going and it doesn't stop. And so working with your doctors to say, what can I do to improve my quality of life? And how can you help me live my best life? And so I'm so grateful to be here. I'm happy to answer any questions, and please feel free to reach out through social media, through email, and good to see you all.